The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, and welcome to Reproaction's Act and Learn webinar for the month of April 2022. We're very excited that you've chosen to join us for today's important topic, which is substance use and pregnancy. So first, we'll introduce your hosts. The first voice you're hearing is Erin Matson. I use she, her pronouns. I am Executive Director and co-founder of Reproaction. I'm based in Washington, D.C., and I am Erin to the Max on Twitter. And I'll let Natalie introduce herself.
Hi, the second voice you're hearing is Natalie Newman. I use she, her pronouns, and I am the executive assistant for Reproaction. I'm based in Milwaukee, Wisconsin, and you can find me on Twitter at Natalie Newman.
Great. And as I have no problem in bragging on the incredible talents of our team at Reproaction. I also just want to lift up that Natalie, before being executive assistant at Reproaction, was an organizer for Reproaction for multiple years, where she led our work on a act in Wisconsin that is being used to criminalize pregnant people over substance use. So she brings a lot of knowledge in organizing to this topic as well. All right, let's talk about the agenda for today. So first, we'll introduce Reproaction. We'll discuss the history of substance use in pregnancy, and we'll talk about how myths turn into policy and criminalization of pregnancy outcomes. Then we'll move into our panel discussion. We're very excited to have two incredible leaders in the field joining us today. Joelle Puccio is a BSN registered nurse and director of education for the Academy of Perinatal Harm Reduction. And we're also extremely excited to be joined by Purvaja Kavattur, research and program associate for the National Advocates for Pregnant Women. And Purvaja, I'm pretty sure I just blew your title, and I'm so sorry. We will correct that in the bio. Sorry about that. And then next steps, we'll cover next steps and Q&A. If you want to live tweet this, that's great. It's really important to get out the word about how both the drug war has brought rampant criminalization, and reproductive oppression has brought rampant criminalization, and the intersection of the two. So if you like to live tweet and that's your jam, we encourage you to do so. Just use the Reproaction hashtag and you'll be able to see one another's tweets. Also want to say that if you have questions at any point in the presentation, you don't have to wait until the end. They can be for anyone who's presenting, any of our panelists. We will get to as many as possible at the end. And with that, I'd just like to introduce Reproaction as an organization. We lead bold action to increase access to abortion and advance reproductive justice. We're fiercely proud of our left flank analysis. We're known for our willingness to hold folks on all sides accountable, whether they're traditionally considered allies or opposition. And we have a deep commitment to nonviolent direct action as one of the tools in our toolbox. And with that, I am thrilled to pass it over to my colleague, Natalie.
Thank you, Erin. Now I'll begin to talk about the history of drug criminalization and the subsequent criminalization of substance use and pregnancy to put our conversation into context. I'll give you a little primer on where it all started, where we are now, and how the war on drugs was essentially a decades-long failed attempt to address public policy and safety by using punitive measures to address societal issues. So the war on drugs was officially declared by President Richard Nixon in 1971, declaring drug abuse to be, quote, public enemy number one. When Ronald Reagan entered office, he expanded the reach of the drug war, leading to a massive increase in incarcerations for nonviolent drug offenses. The number of nonviolent drug offenses during this time went from 50,000 in 1980 to 400,000 in 1997. Reagan's administration focused on criminal punishment rather than treatment for drug users. It's important to note that the new penalties introduced for crack cocaine use were not the same as powder cocaine. At the time, it was widely believed that Black Americans were more likely to use crack cocaine, while white Americans were more likely to use powder cocaine, though this idea was inadequately examined and did not support this claim. There was a definitive racial gap of drug policy enforcement and punitive response due to law enforcement disproportionately focusing on urban areas, low-income communities, and communities of color in policing. This led to higher arrest and incarceration rates for people of color, particularly Black people. Public concern and panic around crack cocaine skyrocketed at this time. Popular media honed in on crack cocaine use and users, which were portrayed as mainly Black crack cocaine users. This idea was pushed by the media, and the public response was mass panic and confirmation of racist stereotypes for white people about Black people. Crack cocaine, which is a cheaper form of cocaine, was ravaging the Black community, and this infiltration of crack in Black communities led to the popular crack baby or crack mother myth. To further put this into context, in a recent New York Times editorial called A Woman's Right, Slandering the Unborn, the phrase, "If the country's war on drugs functions as a system of social control, that control is doubly exercised when a fetus is involved." This phrase really sets a tone for how we answer questions around substance use and pregnancy. Now let's answer the question, what is the crack baby? The quote, crack baby is the idea that babies who were exposed to crack or cocaine in utero were being born, quote, addicted, and the effects of crack cocaine exposure resulted in a generation of permanently damaged children. The idea of the crack baby came from one study done in the 1980s on under 24 pregnant women. This study found that babies whose mothers used crack cocaine while pregnant gave birth to sick, small, and less social babies. Though this theory was later debunked, as we'll go on to discuss, reports began to surface around children who were born to Black mothers that used crack that were neurologically damaged and less than human. Popular media took the idea from that one study and ran with it, further pushing and supporting the claim that the study concluded, although the researcher, Dr. Ira Chasnoff, conceded that he had overstated the concerns and acknowledged that cocaine's ill effects on newborns could be treated. In sum, he noted that mothers that used crack gave birth to smaller, sicker, and less social babies, but noted the limitations on his study and cautioned that further research would be necessary. Again, popular media ran with the findings of this one study, pushing the idea of the crack baby into the public consciousness. Black mothers that used crack were seen as irretrievably depraved and ultimately indifferent to their children. This idea only confirmed what stereotypes and racist attributes white people already had about Black motherhood. Researchers debunked the damaged generation theory numerous times, finding no indication that children exposed to crack in the womb faced long-term debilitation and that the effects were indistinguishable from effects associated with poverty, including homelessness, domestic violence, and malnutrition. When babies are born with, quote, withdrawal-like symptoms, it's important to note that symptoms are transient and treatable by keeping mothers and babies together, by encouraging skin-to-skin contact and breastfeeding, not by punishment or by separating families. By the time popular media recognized that the crack baby was, in fact, a myth, it was too late, and the narrative still persists today in various forms. For example, if you ever heard the phrase oxytot or oxytots, which is essentially a new term for a baby born to a mother that used opioids during pregnancy. This idea, along with others like the quote meth baby, is an extension of the crack baby myth. The American College of Obstetricians and Gynecologists explained that neonatal abstinence syndrome, which is a group of conditions caused when a baby has withdrawal-like symptoms after being exposed to a substance prior to birth, is a quote expected and treatable condition. And further, newborns treated for withdrawal do not develop any differently than other children. Now let's move into how this dangerous myth can evolve into dangerous policy, and how this shows that drunk science and racist attitudes about Black people, specifically Black motherhood, can work together to shape dangerous public policy. In the wake of the crack baby scare, dozens of states debated bills relating to prenatal exposure to drugs, and as a result, prosecutors began arresting mothers who gave birth to, quote, drug-exposed newborns, and a majority of states amended their civil child welfare laws, or their child civil welfare laws, to specifically address substance use during pregnancy. Drug policy around the myth of the crack babies and damaged children and Black motherhood led to the expansion of the already broken child welfare and foster care system. In the book, Killing the Black Body, Race, Reproduction, and the Meaning of Liberty, legal scholar Dorothy Roberts explains that, quote, charges of prenatal crime used to occur twice a decade. Then, in the mid-1980s, prosecutors decided to tackle the panic over an alleged explosion of crack babies by prosecuting their mothers. Next slide, please. Great. Now we'll move on to substance use and pregnancy criminalization and how myths evolved into policy and turned criminalization of pregnancy outcomes and the movement to establish fetuses as constitutional persons under the law. We know that the logical consequence to banning abortion is sending people to jail, full stop. Criminalizing all pregnancy outcomes, no matter what happened, that be a miscarriage, a stillbirth, abortion, full-term birth, or any other pregnancy outcome, is the next step. Abortion opponents were never just gunning for the end of Roe. They want to establish complete constitutional personhood through equal protection for fetuses, zygotes, or even embryos as a way to criminalize pregnancy and prevent abortion. This includes criminalizing the use of substances during pregnancy and policing parenthood as an extension. As of 2017, according to Amnesty International, 4 states considered drug use during pregnancy to be grounds for civil commitment or involuntary detention in a treatment facility. 38 states have fetal assault laws in the book, which considers fetuses as potential victims of a crime. In 2017, 18 states considered substance use during pregnancy to be child abuse. As of April 2022, 24 states consider substance use during pregnancy to be child abuse under civil child welfare statutes, whether or not it causes harm to the fetus. Additionally, according to the Guttmacher Institute, as of April 2022, 25 states and the District of Columbia require healthcare professionals to report suspected prenatal drug use, and 8 states require them to test for prenatal drug exposure if they suspect drug use. It should come as no surprise that Black babies are tested in hospitals for prenatal drug exposure at far higher rates than white babies. Some hospitals have guidelines for screening infants and need to have certain criteria met in order to screen an infant for drugs. In one study, it was found that newborns born to African American mothers were 35% more likely to be tested, with just 13% of white newborns being tested for prenatal drug exposure. Newborns can also be tested without the consent of their parents. It should be made clear that, quote, several studies have found that Black women in particular are subjected to prenatal drug testing at higher rates than women in other racial and ethnic demographics, but do not have higher rates of positives. A study published in the February 2004 issue of Child Abuse and Neglect also found several other factors unrelated to drug use that led to higher testing rates, including single motherhood, tobacco use, a history of preterm labor, and a history of child services involvement, among others. Criminalizing drug use is how the state polices parenting and parenthood, period. It's important to note that every major medical association also opposes the prosecution and punishment of pregnant women. The American Medical Association stated that pregnant women will be more likely to avoid seeking prenatal or open medical care for fear that their physician's knowledge of substance abuse or potentially harmful behavior could result in a jail sentence rather than proper medical treatment. Pregnant people who use substances should be provided with accurate and appropriate medical care from their physicians, not punishment. AMA, the American Medical Association, will oppose any efforts to imply that the diagnosis of substance use disorder during pregnancy represents child abuse. The AMA will also oppose the removal of infants from their mothers solely based on a single positive prenatal drug screen without appropriate evaluation. Now let's define fetal personhood, which is essentially the term and cause that is at the root of this issue. Fetal personhood is the aim to define fertilized eggs, embryos, and fetuses as legal persons, essentially trying to establish fetuses as completely separate from the pregnant person, often resulting in the criminalization of pregnancy and pregnancy outcomes. This grants fetuses full personhood rights under the Constitution and establishes fetuses as whole persons with independent rights. The original purpose of some of these fetal personhood measures was to allegedly protect pregnant women from violence, but these laws are used to criminalize pregnant women, pregnant people, and their actions during their pregnancies. According to Dana Sussman, Deputy Executive Director of NAPW, fetal personhood is about normalizing the idea that a pregnant person is not their own person anymore, that they're subservient to the rights, individuality, and full personhood of a fetus. An example of laws that use fetal personhood to punish pregnant people is Wisconsin Unborn Child Protection Act, also known as Wisconsin Action 92, or the Cocaine Mom Law, which Erin mentioned previously. This law, which was ruled unconstitutional, allows for the detention and prosecution of pregnant people that are suspected of using substances during pregnancy. The creation of this law comes directly from the crack baby myth and comes from a place of trying to establish full personhood protection for fetuses. There are laws similar to Wisconsin's all over the country, but this law is unique as the proceedings are held in secret, and the juvenile court allows for the court to take physical custody of a pregnant person and lock them up. Fetal personhood laws are an extension of criminalizing substance use and pregnancy, and thereby criminalizing all pregnancy outcomes. These measures are incredibly dangerous because you cannot separate a pregnant person from their pregnancy, as these laws intend to do. Criminalizing pregnancy outcomes and thus throwing people in jail for detention does little to help public health overall. These measures also include laws similar to feticide, fetal assault laws, fetal homicide laws, fetal protection laws, among others. These initiatives contravene international human rights standards, which confirm that human rights protections do not apply before birth, according to the UN. Again, as of 2017, 38 states had laws stating that fetuses could be victims of a crime. 23 of those states applied these laws at any stage of gestation. I'm going to give a few examples of fetal personhood laws and how they entrap people in real time. First, I'll talk about Tammy Laisher of Wisconsin. Tammy suffered from a severe thyroid condition and depression and started to self-medicate infrequently with methamphetamines when she lost her job, and subsequently lost her insurance and the ability to get the medication she needed to treat her thyroid condition. When she suspected that she may be pregnant, she stopped using methamphetamines and sought the help of social service workers who referred her to the local ER. After confiding in her medical team about her past drug use, a hospital staff member reported her to the state under Act 292. Following this, Tammy was taken to court and a lawyer was assigned to her fetus. Tammy was not allowed a lawyer. After staying overnight in the hospital, she was told by a judge that she had to sign a petition to initiate protective action on her fetus. After some back and forth and a threat of being sent to an unnecessary drug treatment program by the state, she was prescribed medication and was sent home. 10 days later, Tammy was arrested and placed in jail for contempt of the court and was held for 18 days. 3 of those days were in solitary confinement. Her requests for prenatal care were denied by jail staff after experiencing some troubling symptoms, and she was told that she should not have gotten herself in this situation if she needed access to prenatal care. Tammy eventually won her release with the help of her assigned public defender and gave birth to a healthy baby in 2015. Tammy has since had to move out of the state of Wisconsin multiple times to avoid the stigma and treatment that she experienced due to this case in her northern Wisconsin town. This law is still being used to punish pregnant people in Wisconsin today. I'll just give you a little quick rundown of other examples of what happens when pregnant people are criminalized under fetal personhood measures. You may have heard of these cases before. First, I'll talk about Brittany Poole of Oklahoma. Brittany was arrested after experiencing a miscarriage at 17 weeks and was convicted of manslaughter in the first degree and was sentenced to 4 years in jail. Despite zero evidence to back up their claim, the prosecutor on this case falsely claimed that the miscarriage was a result of controlled substance use in the form of methamphetamines, though her pregnancy was likely lost due to fetal viability. However, despite a lack of medical science and evidence in the case, the prosecutor moved forward with the charge. I'll talk about Kim Wallach of Alabama. Kim had a lawful and long-time prescription for hydrocodone that she had taken for years to manage a degenerative disc disease that had been exacerbated by a previous surgery and a car crash. Kim resumed taking her prescription after a hiatus at 34 weeks pregnant to manage her debilitating back pain. After giving birth and telling her OBGYN about the prescription, her newborn son was tested positive for this drug. Shortly after her and her baby were released from the hospital, the Department of Human Resources followed up and closed her case after she provided proof of the prescription. Later, though, she was charged by the Florida Police Department and the Lauderdale District Attorney's Office with a prescription fraud for not telling her orthopedist that she was pregnant. Alabama has charged hundreds of pregnant people with chemical endangerment prior to this case, however. Alabama's chemical endangerment law excluded women who obtained prescriptions legally while pregnant, and National Advocacy of Pregnant Women says that the state and legislature is circumventing the system by charging them with prescription fraud. One more example that I'll give you is Lizelle Herrera. This is an incredibly recent case related to a horrifying abortion ban in Texas called SB 8. Lizelle was arrested in early 2022 on the charge of murder for allegedly self-inducing an abortion in January of last year. Though the charges were dropped, the damage was done. Lizelle spent 3 days in jail before being bailed out by the If, When, How Legal Defense Fund. These are only a few of the most recent high-profile cases. This is what happens when the rights of a fetus, zygote, or embryo supersede the rights of the pregnant person. This is what can happen when the state attempts to exert control and surveillance over pregnant people and their actions and decisions during pregnancy. Now that we've covered the criminalization of drug use, the crack baby myth, and how myths like these turn into dangerous policy and criminalization, including fetal personhood, I will pass it over to Erin to ask our panelists Joelle questions about drug use in pregnancy as a public health concern. Thank you.
Thank you so much, Natalie, for that extremely comprehensive presentation. So I'm super excited to be joined by Joelle Puccio, who uses they, them pronouns. And Joelle is a registered nurse with 17 years of experience in perinatal and neonatal intensive care. They worked for 7 years as the Director of Women's Services for the People's Harm Reduction Alliance, a peer-run syringe access program in Seattle, Washington, and served on their board of directors. They've spoken at a variety of conferences, including the Drug Policy Alliance, the CDC, Harm Reduction Coalition, the Office of National Drug Control Policy, the American College of Obstetricians and Gynecologists, and more. They currently travel the country in their RV, and I believe we're actually looking at video feed of the RV. And I also noticed some cat towers in the background, and I just all snaps to all of this. This is amazing. Yes, traveling with their partner and 2 cats as a travel nurse in order to learn about the experiences of families affected by perinatal substance use and pregnancy criminalization around the country. Their main interest is the intersection of drug user rights and feminism. They became passionate about advocating for people who use drugs after realizing that everything they had been taught about drugs from childhood through nursing school was wrong. Joelle, thank you so much for joining us today. Thrilled to have your expertise here.
I'm so happy to be here. Thank you for having me. And I think it's a little messy in here while we're driving, but there's my cat right there. I don't know if everybody can see her. She's just chilling out.
Oh my
There's another one running around here somewhere as well.
I can't stop loving feminism. Thank you for that. So such an intersection. So let's talk shop a bit. What do we know and what don't we know about substance use during pregnancy, specifically the science and the medicine?
So we really know very little. And part of that is because, it's really difficult to do any kind of research on pregnancy at all. You can't design a study ethically that says, hey, come smoke meth for a couple months and we'll see what happens to your baby. Like, nobody's going to do that study. Nobody's going to fund that study. That study can't happen. Excuse me. What we do know is mostly associations. And there's a really big difference between an association and a cause and effect relationship. So the example that I use to kind of describe this idea is that if you were an alien from outer space and you wanted to come to Earth and study weather patterns, you would say, I notice that when people open up their umbrellas, it's often raining. So you might come to the conclusion that umbrellas cause rainfall because you see these things together often. But it could be the opposite, that rainfall causes umbrellas in this case, or they could be completely unrelated things. And so when we notice that a lot of people who use drugs, for example, a larger proportion of people who use drugs have mental health issues than the general population, we could think about that in so many different ways, but it's not necessarily a cause and effect relationship. We don't know based on these things occurring together that one causes the other. And so when we look at substance use research, the only substances for which we do see very strong indications of a cause and effect relationship are alcohol and tobacco or smoking. And so when we think about what we know about substance use, it's almost nothing. It's very, very little, and it's very difficult to design the kinds of studies that can parse out, is this a cause or is this just something that is a coincidence? And the way to do that is to design studies where you have 2 large groups of people that have everything in common except substance use. And it's almost impossible to do that because when you are a person in this country, and particularly someone with the capacity for pregnancy, if you use substances, you're not going to be exactly like everybody else. You're going to suffer from discrimination in employment and in housing and in education, and you're going to suffer from surveillance and negative interactions with, certainly law enforcement, but also other folks in your life. So it's really, really, really difficult to find that cause and effect relationship that would be really nice if we had it, but we just honestly don't.
Thank you for that. I really appreciate that grounding and context. So my next question, I'm going to start, and feel free to shape what I say. You are the expert. This is my memory from a few years back. But a few years ago, I was at, I believe it was an Abortion Care Network conference, and I attended an absolutely spectacular panel that was talking about drug use in pregnancy and substance use in pregnancy and alcohol in pregnancy. And one of the things that was presented was this idea that actually, for example, the fairly widespread practice of sometimes they'll have signs up in bars that show a person with a pregnant belly and a warning about alcohol actually lead to worse outcomes than not having a sign whatsoever. And so I kind of say that as background to, what do you think are the appropriate things that folks should be saying about substance use during pregnancy, either directly to people who use substances or just more generally as a culture? What should we be saying?
Well, I think it's important to acknowledge the very, very serious risks of particularly alcohol. Alcohol is the only substance for which we have strong data suggesting severe and permanent harm to children exposed. And so when someone is using multiple substances, which is fairly typical, I mean, we all do. We use caffeine and nicotine and alcohol and maybe some other stuff when we party. So I would advise people start with alcohol. That's the biggest one. If you can change one thing about your substance use, decrease or stop drinking alcohol. But then after that, I think there's this saying that Dan Bigg and the Chicago Recovery Alliance have popularized several decades ago. And it's just, if you boil harm reduction all the way down, this is what it is. It's just 3 words, and it is any positive change. Any positive change. So that means if you go from smoking 20 cigarettes a day to 19 cigarettes a day, that is amazing and wonderful, and we should celebrate that. And that is what I want to say to people who are using substances when they're pregnant, because our society gives us this idea, and a lot of it comes from, 12-step and AA and NA and those types of things, which can be super helpful to a lot of people. But the one thing that people learn in those groups that I just really want to push back against is this idea of one drink, one drunk. It's all or nothing. If you have one sip, you might as well be hammered. And that's just not true. There is always a chance to make a positive change. Even if you're 5 drinks in and you decide to stop, that's a positive change. And I want to support people in making any positive change as defined by them, however small. That's what we need to be telling people.
Any positive change. That is a beautiful thought that extends far beyond the scope of this webinar and the discussion. So thank you for that. Really appreciate that. And thank you for that grounding. So my next question is, and specifically, what's your beat on policy targeting people who use substances? Does that actually help improve outcomes?
As it stands in our country and in our healthcare system, no, it is actively harmful. What we have right now is a system of surveillance and punishment, which discourages people from seeking help and discourages them from having honest and open conversations with their healthcare providers. Because of our hospital to prison pipeline, which is, again, a whole other webinar, and me as a nurse, our complicitness with the prison industrial system and the surveillance state, we have created the ideal system if we wanted to do as much harm as possible to people who use drugs, and particularly pregnant people who use drugs. So a system that would be beneficial would be a system that treated substance use disorder like we treat other illnesses and medical conditions, where if you ask for help, you get it. We don't take somebody who has cancer and say, well, you need to stop having cancer before we're going to give you chemo. But we take people with substance use disorders and say, you need to stop using substances or we're not going to help you with your substance use disorder. It's mind-blowingly absurd the way we do things in this country. And I think that's because out of one side of our mouth, we say substance use disorder is, a behavioral and medical condition. And out of the other side of our mouth, we say it's a criminal act. And we can't have both of those things be true at the same time. So we need to pick one, ideally the right one, and make policies based on helping people rather than punishing people. Because when you punish a pregnant person or a parent of small children, you're punishing babies and children. Babies want their mothers. They want their parents, and they don't want to be, taken out of their arms. Babies want to be able to breastfeed and chest feed and have access to human milk. And so this, like Natalie mentioned earlier, this idea that a pregnant person and a fetus are a separate thing with separate goals and separate, a way to be beneficial to one without the other doesn't exist. There's another idea that I love. I forget the name of the pediatrician who popularized this one, but they say there's no such thing as a baby. If you try to describe a baby, you will find yourself describing a relationship between a baby and someone. And like as a NICU nurse, when I get reports on my babies for the day, it starts with, this is the mother, this is their health history, and this is the relationship with this baby. And so we have to cherish and value that codependency, which is not a bad word, and really make it okay and make it easier for people to access care and to make better choices. Because if you're hiding and you're alone and you're ashamed, you're not going to be able to make good choices about your life and your health.
Thank you so much for that. That was profound. Again, really enjoying having you here on this panel. So time for one or two more questions before we go to Purvaja. So Natalie laid out the crack baby myth in detail and really appreciate how she did that. And she also mentioned the oxytot, which is another slur that is now being used against children of people whose parents used substances during pregnancy. And I just want to ask, do you see these come up in your work? And I also want to dig a little deeper in these questions because this is not a race neutral question. And given that the crack baby myth is, another way to call it is just a racist myth, focused especially on Black women. How do you see that coming up? And I'm just really curious to any thoughts you have.
So it's so much easier as an individual and as a society to decide that drugs are bad. And so once we find out someone's using drugs, we don't have to think about them anymore. We can categorize them as in the bad column. And we don't have to look at the way our country treats people of color, Black people and Indigenous people in particular. And we don't have to think about how we've decimated our public education system and housing and healthcare, particularly mental health care. And we don't have to look at ourselves and the way that we have created this environment that makes this problem. And it's just so much easier to find drugs and then stop looking. And it's also it's a more interesting story. Sensationalism is what sells, and it sells on both sides. I love it that you all kind of push back on whoever, regardless of their political leaning, because I find the same thing in drug user activism. We have the propaganda from the state and from the healthcare system saying, you know, if you use drugs, your baby will be born with 6 arms and it'll be a monster and a drain on society. And that's obviously not true. But then we also have activists saying that everybody should use drugs and it's fine and it's great and it's healthy. And that's not entirely true either. I once did a talk at a cannabis conference, and afterwards this woman came up to me and said, I smoked every day, all day when I was pregnant, as if that was, you know, I feel rather neutral about that, but she expected me to be like, that's wonderful, that's amazing. And I said, oh, well, I don't advise anybody to use any recreational substance during pregnancy, including cannabis and caffeine. And that was kind of shocking to the activist side. And so, honestly, the truth is much more mundane. Drugs are not as dangerous for pregnancy as we've been led to believe, but they're also not entirely benign either. So I think when people are using substances for a purpose, like to help with morning sickness or for, you know, performance enhancement because you're a single mom with 3 kids and 8 jobs, then that's a little bit muddier water. But it really isn't like these two extremes that we hear all the time. The truth is somewhere in the middle.
Thank you so much, Joelle. Really appreciate your comments today. I'm going to pass it over to Natalie, who's going to move to the next section of our panel with Purvaja.
Hi, this is Natalie again. I would like to introduce Purvaja Kavattur. She is a research and program associate at the National Advocacy for Pregnant Women, also referred to as NAPW. Through this role, she provides research translation to attorneys, as well as documents arrests for forced medical interventions on pregnant people. Prior to NAPW, she has had a professional background in international human rights, as well as maternal and menstrual health in the Global South. Her past research has examined U.S. transmasculine adolescent abortion experience and the influence of scientific literature on abortion jurisprudence. Purvaja has a Master of Science in Global Health and Population from Harvard T.H. Chan School of Public Health, and a Science in Social Policy and Economics from the London School of Economics. Purvaja, thank you so much for joining us today.
Thank you for having me.
Yeah, I will just dive right into the questions. So you translate research and science for attorneys. What exactly does that mean? How does your work impact NAPW and the people who come to your organization for help?
Sure. What's a researcher doing at a legal organization? So yes, NAPW is a legal organization. However, our work is not limited to litigation. We also work on public education, coalition building, and conducting independent research, because we understand that change does not simply come from courtrooms, and our staff really tries to reflect that. We have people with social work backgrounds, nursing backgrounds, strategic litigation, public defense, and research. So as a researcher, the way I help out with litigation is I ensure that we are using the most up-to-date and scientifically robust studies to back up our letters and our briefs, and ensure that when we are citing literature, that it's done so accurately. When we have allies, I also make sure to send science to them. And when we have client intakes who come in and we find that research might help them in resisting detention or coercive medical procedures, I'll be sure to pass that on to our clients as well. In terms of coalition building, I work to build relationships with other public health researchers, medical researchers, and legal thinkers so that we can have them sign on to our briefs, our letters, and provide expert testimony in our cases, but also really to understand what the lay of the land is in terms of research so that all our public education is very much evidence-based. And we also conduct independent research. So in a very traditional research sense, I'm working with a team at NAPW to document all the arrests and forced medical interventions on pregnant people from Roe v. Wade all the way up to 2020. So in our old arrest report from 1973, Roe, to 2020, we've documented over 400 such arrests. And I'm part of the revamp of that study. And from 2006 to 2020, we've documented over 1,200 such cases. So triple the number of arrests in half the time. And my role as a researcher is to help in that documentation work and spread awareness of our findings as they emerge with the public.
Awesome. Thank you so much for that. Something I just wanted to highlight was when you said change doesn't come from courtrooms, and that could not be truer. I'll move on to my second question. In your work as a research translation associate, are you seeing any patterns around criminalization or language, or really anything else in regards to substance use in pregnancy? And if so, what are they?
Yeah. So in our earlier arrest report, over 84% of our cases involve allegations of substance use, of controlled substance use. We don't have the exact numbers for our updated study, but we project a similarly high proportion of our cases to involve allegations of controlled substance use. And the reason why I say that is because the top 3 states with the most number of arrests represent over 60% of all the cases that we document. And they have all either had or have laws in place that directly or can be interpreted to criminalize pregnant people who use drugs. And those 3 states are Alabama with 544 cases, South Carolina with 175 cases, and Tennessee with 125 cases. And I'll speak about those 3 states, but overall, nationally, we are seeing that communities, low-income communities, rural communities, and communities of color are the ones who are most targeted disproportionately. But looking at these 3 states, so in Alabama, most of our arrests are under the chemical endangerment law, which was intended to criminalize people who expose children to environments in which controlled substances are produced or distributed, specifically meth labs. However, Alabama, by extending the definition of a child to include a viable fetus, has used this law over 500 times in the past 15 years to criminalize pregnant people who expose their fetus to substances, despite the fact that controlled substances don't cause miscarriages or stillbirths. Moving on to Tennessee, in 2014, Tennessee became the first state in the US to directly allow the prosecution of pregnant people who use drugs under the fetal assault law. However, fortunately, in 2016, that law is no longer in effect, and that's thanks to the work of many public health and medical professionals and organizations who oppose the punitive and criminal actions on pregnant people who use drugs, because criminalization, penalization, and surveillance harms and, in fact, lowers maternal, child, and fetal health outcomes. And then finally, moving to South Carolina, the other 2 states have laws in effect that were guiding these arrests, whereas in South Carolina, there are 2 judicial decisions that have expanded the criminal child abuse codes and the homicide codes that were both in the 90s, but are still being used today to criminalize pregnant people who use drugs. So in 1992, in the Whitner case, Cornelia Whitner had a healthy baby who had a positive toxicology for cocaine. On that basis alone, the state charged her with criminal child abuse, claiming that her viable fetus was a child under the criminal child abuse code. And so SCOTUS has refused to hear this case, and people in South Carolina continue to be prosecuted for child abuse, for drug use during pregnancy, and any risky behaviors during pregnancy, which is incredibly vague. And then the other case is in 1999, the McKnight case, where Regina McKnight became the first woman in the United States to be convicted of homicide by child abuse for experiencing a stillbirth. And this again is because South Carolina defines a child to include a viable fetus in the criminal homicide code. So overall, the trends are, we're going to see an uptick, and it's incredibly scary for pregnancy rights.
Thank you so much for that awesome overview. That was really detailed. So you did talk about this in my last question to you, but I'll ask this anyways if you want to reiterate anything. Criminalizing substance use and pregnancy fit into the larger context of criminalizing pregnancy outcomes?
Yeah, so as I've discussed, the majority of our cases involve allegations of substance use. However, they are not fundamentally substance use crimes. Instead, relying on the stigma associated with substance use, state actors have identified pregnant people who use drugs as an entry point, an intervention point, and a mechanism through which prosecutors can expand their criminal child abuse codes, neglect codes, and child endangerment codes, as well as their murder codes, to target, control, and surveil actions during pregnancy. Said another way, substance use is a gateway to broader pregnancy criminalization. And so typically, as we all know, crimes under child neglect or murder are not limited to substance use. So with that in mind, returning back to the Whitner case in South Carolina, Cornelia's case was supposed to only be about pregnancy and the use of one drug, cocaine. However, she was charged with criminal child abuse, which, as we know, is not a crime specific to drug use or possession. And this was all reliant on defining a fetus as a child. And then additionally, the vague language of the Whitner decision has opened up criminalization for all actions during pregnancy outside of substance use as well, to risky behaviors, including people who've attempted suicide while pregnant. Instead, getting help and support, they are criminalized. So overall, nationally, yes, the majority of our cases involve allegations of substance use, but the actual crimes and charges that these pregnant people face are of child abuse and neglect, and murder. And so overall, pregnancy criminalization intersecting with substance use is about a larger, more concerted effort to criminalize pregnancy.
Thank you for that. And to round out, moving to the future, what can we expect of fetal personhood measures now with Roe long meaningless for many and losing power soon? How do we expect criminalization of pregnancy to take form going forward?
The quick answer is that we are going to see and have seen an increase in fetal personhood legislation, and we're going to see an expansion of what pregnancy criminalization looks like. So as you yourself discussed in your slides earlier on, there are just so many ways that substance use and pregnancy are being criminalized, and much of this hinges on fetal personhood. And from our own internal policy documentation at NAPW in 2022, really scary. We have seen the most fetal personhood measures that we've ever documented before. And this is across many different states. And typically these bills are housed under health or pregnancy-related bills. Increasingly, we're starting to see model language in seemingly innocuous statutes such as divorce, inheritance, and tax. So fetal personhood language is propping up everywhere and anywhere, and it's incredibly worrying because it points to this expanding scope of control. And it also points to the fact that the sites of pregnancy criminalization are expanding. From our own work, we've seen medical and social welfare institutions turn into sites for criminalization. We've seen car parks, in the case of Marsha Jones that you raised, and people's own homes and staircases turn into sites for criminalization. the types of sites and actors involved in criminalizing pregnancy is increasing. And this is all with Roe on the books, as limited as it is for several states. We win a lot of our cases because on appeal, all these charges are blatantly unconstitutional under Roe. So you can imagine what will happen when we lose that right. But not to end on an entirely negative note, yes, the criminalization is going up, is on the rise, but so is our movement. From a legal defense perspective, we are going to be using much more creative approaches and strategies outside of Roe as places turn into sites for criminalization. These also become new places where we engage with new allies. And as we know from history, when our rights are being denied more publicly, more people are going to get involved in joining our movement.
Thank you so much for that awesome overview. You've been such a great panelist, as well as Joelle. Thank you so much, Purvaja, for your participation in this webinar. I will pass it back to Erin to round us out. Thank you.
Thank you so much, Natalie and Purvaja. That was wonderful. So please plug into our campaigns. So we host these Act and Learn webinars every month, and they are free and open to the public, and we want to invite you. So don't ever have fear of missing out. You can sign up for email alerts at www.reproaction.org, and we'll make sure that you get your personalized invitation to join us. Please also follow us on social media. We are Reproaction on Facebook, Twitter, and Instagram. And please save the date for our next Act and Learn webinar, which will focus on self-care for activists, a really important thing as we know that this is going to be challenging times up ahead for advocates for reproductive health rights and justice. So we'll meet on Wednesday, May 11th at 12 noon Eastern. As long as you sign up for our email alerts at reproaction.org, you will most definitely get your invitation, and we'd love to see you there. So with that, I'm going to open it up to Q&A. I'm actually going to take a little moderator privilege first, and I'd love for both Joelle and Purvaja to answer this. So we have activists who attend these webinars every month. If there is one thing that you would like folks to do or change in their approach to substance use and pregnancy, what would you like them to change or do?
I can jump in. So this is probably, maybe, I'm definitely not the answer that you were looking for or expecting, but what I have been focusing on with myself and with others in the past year is self-care, because we as activists, we suck at it and we burn out constantly. I feel burnt out all the time. And I would like us all to take inspiration from Simone Biles and Naomi Osaka last summer, stepping down and saying, I need this time for me. And that's what I would tell activists. It's okay to take some time and stop. Lynn Paltrow of NAPW told me a few days ago that it's so important to do self-care, and this work is always going to be here, and it's always going to benefit from you when you come back. And that's what I would tell activists.
That's awesome, and very timely, as we also just said. That's our webinar too. That's awesome, and love that we're talking about Lynn Paltrow, of course. So we'll pass it over to Purvaja, who gets to work with Lynn every day.
Oh, it's a great pleasure to work with her. In addition to what Joelle says, often I feel like as a researcher studying substance use and pregnancy, it's often devoid of the voices of people who live with using substances while being pregnant. And so I think in our engagement and our activism, we should be lifting up those voices, but also having them speak and us listening. So that's my thing that I'd like to see more.
Yes, I echo that 1000%. Be led by people who use drugs.
Excellent. Thank you so much for that. Okay. Um, I'd love to hear more about, and I think let's start with Joelle on this one. If I'm wrong, tell me and we'll go to Purvaja on it. But if you could talk a little more about mandatory reporting laws for healthcare professionals that either exist or maybe misperceptions about what may be the law.
Yeah, so what has been my experience is that most nurses and doctors and social workers have no idea what the law says, and they just assume that it's mandatory for them to report such and such a thing. In many states, it is not, and I think Purvaja will know better how to address those intricacies of the law. But I also want to point out that in many states, it is not specified in those laws who you have to report to. And so we have the ability in our areas of influence, in our states, in our localities, to create agencies that actually do help, so that we're not having to report to law enforcement or social services, which oftentimes, as another Lynn Paltrowism, the number one funded intervention is child removal, not helping families. And so I think it's really important what we mandatorily report. And I think for healthcare professionals as well, it's extremely important to document accurately. Every policy I've ever seen says if you're going to do a drug test, you need to document the reason why. And I have been doing this for 18 years, and I have never seen anyone document an adequate medical reason for doing a drug test. So I think mandatory reporting, I even want to take a step back to what are you reporting? How are you collecting this information? And are you doing it for a medical reason, or are you doing it as an agent of the state collecting evidence against your patient, which is unethical and probably illegal in most places?
Don't have much more to add, but to plug an NAPW event that we had last night, and the recording will be coming out soon. We had a webinar called Demanding an Abolitionist Model of Social Work in Reproductive Justice, which talks about this with amazing speakers. But essentially, I think two key points that I took away from that webinar and somewhat addresses your point is that, one, we shouldn't, this is a system, no system that purports to be about child welfare will mimic how we criminalize adults. And so we should be trying to move away from that. But then also, again, I'm not a social worker, but defer to Joelle and maybe this webinar. But also we think of mandated reporting to the state and to CPS, but often these are issues of poverty, of hunger, of lack of access to medical care or harm reduction. And so maybe in addition, if maybe we don't report to CPS, but in addition to that, trying to make linkages with food banks, trying to make linkages with mutual aid funds for these families.
Thank you so much. All right, I think the remaining questions we have are deeper ones that will be hard to wrap in less than 2 minutes. So I'm going to end there on that note. Thank you so much to our panelists, to Joelle, to Purvaja. Thank you so much for your time today and for sharing your expertise. Thank you to everyone who came and for bringing your hearts and your minds. And we know, we trust that you'll carry this in your activism moving forward. And a very special thank you to Natalie Newman on our team, who really pulled together a spectacular webinar, recruited amazing panelists, and gave us such a fantastic and detailed grounding presentation to get us started. So thank you so, so much, everyone. Have a very lovely rest of your day. Goodbye.